because this is part of the Twin Trust webinar. So the Twin Trust is a charity of the UK, Twin and Multiple Pregnancy. They jointly with St. George's University and the Trust set up the first Twin Trust Center for Research and Clinical Excellence. That was back in 2020, and we've been, as part of the activities that we do, is that we have this regular webinars, it's mainly educational webinars, and at the moment we're doing it monthly. So these webinars are recorded and they're available also on the website for people to access. We have a lot of registration, and roughly about half or a third of the people who actually register join live, but they have access to the recording. They also have access to certificate of you being have attended the webinar, and also the feedback. We really want it to be interactive. I personally enjoy the discussion. I think it's a fantastic opportunity to have really the eminent experts in this area that being with us today, sharing expertise, 15 minutes, summary of the article, and then having the discussion. So please feel free to engage and ask questions. We tend to mute everyone so that we don't have any interruption of the speaker. And therefore, if you want to have any questions, please use the chat function to post your questions. I promise I'll make sure that we go through all of them. Okay, so the next is Yuval Fox, who is going to talk to us about twinning in ART and single embryo transfer. So Yuval, are you happy to share your screen and go ahead with your talk?
Definitely. Just a second, can you hear me well?
Yes.
Terrific. And the screen is okay?
Yes, we can see the lovely animation there.
Okay, terrific. And now can you see all the screen or just part of it?
Part of it.
Okay, so let me just adjust it in some way. Okay. Hopefully solved?
Yes.
Terrific. So hello, and thank you for the invitation and for the opportunity to share this work through this platform. And just a bit about myself. I'm an Israeli doctor. I'm a reproductive fellow in Tel Aviv Medical Center, and I'm also a research fellow in Boston IVF in Massachusetts. I'm doing a master's at Harvard Chan, focusing on quantitative methods. And I will share with you some of the topics in our review called Twining in ART, the elective single embryo transfer policies. Different in a sense that it is more a reproductive ART perspective. I consider this topic as particularly interesting, first because it's in an exceptional example of a large-scale healthcare policy change. It was a gradual policy change and centralized and decentralized in some countries, in a sense that some countries act together, some others not and joined. And we have like a constant documentation of those shifts. So we can analyze it really well. And the second reason that I consider this topic is interesting is that ESET, the elective single embryo transfer, is often and still a source of many tensions, at least where I did my training, between REIs and MFMs. And there is no collective right or wrong, of course, and it is basically a decision science question to deal with. So let's start. It is more than 30 years that perinatologists and healthcare personnel aim to reduce morbidity associated with multiple pregnancy, and the elective single embryo transfer is a policy adopted in order to deal with this. It's a procedure in which one embryo is selected from a larger number of available embryos and introduced into the uterus. And in this section, we will work through the evidence, the safety, the efficacy, patient's autonomy and patient will, which is highly important in this topic, guidelines and patient selection, the implementation of PGTA as an off-label procedure, of course, and how is it used in this field. So over the past 3 decades, ART success rates were characterized with a continuous improvement in its efficacy, and that was evidenced by a remarkable surge in live birth rates per transfer. from roughly 15% in the mid-80s of the 20th century. And this has reached to a rate of roughly 35% in 2014, 2015. And this increase has been attributed to several key factors, including increased numbers and relative efficacy of cryopreservation, vitrification, mostly survival, embryo selection and improved quality of culture media, the wide implementation of ICSI, surrogacy, and also gamete donation. And those changes occurred almost in parallel with the increase of practice and adaptation of elective single embryo transfer that first introduced in 1919. And this resulted with a decrease in cycles of 2 or more embryos and a reduction in number of multiple pregnancies. The increase in pregnancy rate in IVF was always coupled with concerns about the associated morbidity and mortality of multiple pregnancy. And taken together, those lead to attempts to restrict the number of transferred embryos and to gradually reduce the acceptable number of transferred embryos, particularly in younger women. And in this figure, we can see the percentage of transfers according to transfer order between 1 embryos, 2 embryos, 3 and more in the left, and the percentages of single infants, twins, and triplets in the right. So the aforementioned factors that I just talked about led to increasing pregnancy rates in IVF, and those factors are all intertwined with the implementation of elective single embryo transfers. So it is really hard to determine the true causal effect of elective single embryo transfer throughout all the sectors. So those two graphs are just representative, and they're not necessarily a cause and effect left to right, okay? So that's one thing to mention. Numerous studies compared the pregnancy outcomes between elective single embryo transfer and DET. That means double embryo transfer or more. That means that most of the studies compared single elective embryo transfers versus double. And studies have constantly showed both obstetrical and neonatal complications to be significantly increased with multiple gestations. And as MFMs here, you are all well aware of the high order pregnancy complications, and I'm not going to elaborate about that. But as we will walk through this, you will see that there have been dramatic measures that have been taken to control those risks by increasing the proportion of ESETs in multiple pregnancy rate. However, it still remains relatively high among patients that conceived through ART. Outcome measures are very important to understand how ESET and double elective embryo transfer are comparable. And we could have wrong statistical inferences very easily here. So the studies and the policy advocated are to be defined as healthy single embryo transfer, and that's not very easy to compare for each study in terms of heterogeneity. But it's also the cumulative live birth term. That means the fresh cycle with the subsequent thaw cycles all combined. The results of those studies practically assert that the cumulative live birth rates after the subsequent replacement of a single frozen embryo is comparable, not superior, of course, when it comes together with the risks to double embryo transfer group. And some of these studies revealed a slight insignificantly advantage towards double embryo transfer. And we will talk about the specific population who have those advantages. Most studies, and that's the problem, reported results of elective single embryo transfers that focused on patients with good prognosis. However, patients with advanced maternal age, patients with low ovarian reserve, and those who supposed to undergo more embryo transfer may face with harder dilemma when we advocate them to go towards elective single embryo transfer. And the elective single embryo transfer approach does not fit for all patients. As you can see here, it is not implemented in all the populations. This approach basically shifts since patients with low response and especially low high maternal advanced maternal age and low ovarian reserve patients do have both qualitative declines and quantitative number of gametes declines. That means we have more haploidities, we have lower morphology scores, and of course lower total numbers. And when we want to talk about the guidelines that bring us to the fertility societies, both in the US and Europe and the UK, the fertility clinical societies, the ASRM and the ACE, have produced guidelines to select the appropriate candidates for elective single embryo transfers. And the algorithms in those practice guidelines aim to identify patients who are at maybe the greatest risks of adverse outcomes by using various attributes such as maternal age and obstetrical history, gynecological history, ovarian response, and the number of embryos that were created and their qualities. But the available data actually suggests that the chance of having twins pregnancy per conceptus is similar throughout all patients. And this means that the absolute risks of twins is actually, and the morbidity is actually the greatest with the base prognosis chunk. So they have the most conceptions, and therefore this is the very subgroup of patients that we should aim to implement the elective single embryo transfer here. Nevertheless, a good quality of evidence regarding to whom we should apply the strategy of these sets and which of the groups would benefit the most of elective single embryo transfer is actually still lacking. As you might notice, the ASRM and the other guidelines differ. In the ASR, in the American Society, we can see that they specifically address the ploidity status of the embryo. And the reason for this is that knowing the ploidity status of an embryo could actually give us a valuable information about the odds of this pregnancy to implement. So here in this figure, we can see that the percentages of assisted reproductive technology cycles using fresh autologous oocytes or embryos that resulted in actual pregnancy and live birth. The embryonic aneuploidity results from several types of chromosomal segregation errors. We all know that. And those segregation errors affect exceptionally high number of human conception, and they cause infertility and miscarriages and congenital disorders. And basically, as we can see in the figures from the right, they actually shape our human reproductive lifespan. And they are the rate limiting factor for reproduction. And the embryo quality and ploidity actually are both pivotal for embryo selection. And therefore, it is important for successful elective single embryo transfer that aims to reduce multiple pregnancy. It's actually an off-label indication. And I'm not here to advocate about the use of PGT for the broad population in the IVF. So ploidity assessment has therefore become part of the metrics. And this determines the quantity of embryos to transfer, at least in the ASRM 2017 guidelines. Let's talk about patient's perspective and patient will. I would say that terms such as singleton live birth and singleton pregnancies may appeal to obstetricians and to perinatologists. However, this notion may not always be favored by all patients. And it is sometimes hard to advocate in medical encounters towards ESET. Patients with long-standing repeated poor success of treatment may find it difficult to see beyond just achieving pregnancy. And we all see that as caregivers. And for us, the caregiver, is sometimes almost ironic that patients who actually bear the treatment's risks often view this differently and ignore those risks. But it's also evident that from a patient point of view, twin pregnancy could actually be often desirable, and risks could be perceived as acceptable. Qualitative studies from Australia, from the US, and also from Europe has shown consistently that patients often view elective single embryo transfer as unfair, depends on their success rates. This has also been checked longitudinally in qualitative studies. So to sum, multiple pregnancy does not only increase the odds for fetal risks such as prematurity and infant mortality, but it's also associated with maternal morbidity and adds a substantial burden to the overall healthcare expenditure. Accumulating evidence favor well-constructed national elective single embryo transfer program. Although cumulative cycles with cryopreservation maintain success rates, it is important to consider that multiple cycles are associated with then emotional, physical burdens and substantial costs. It is vital when choosing, when considering the quantity of embryos to transfer, that the doctor will ensure the needs and preferences of the specific patients, taking all into account after disclosing the short and the long-term consequences of multiple pregnancy. And despite the potential to maintain overall live birth rates with the elective single embryo transfer strategy, many patients undertaking fertility treatments will continue to indicate a clear preference for twins. And the final point is that the cost effectiveness of double embryo transfer may improve with age, and the extended treatments in duration, a complete ESET program, may be disadvantages to older patients whose fertility is declining rapidly because the oocytes aneuploidity, which is the biggest actually concern. Thank you very much. Thank you.
Thank you so much, Yuval. That was really wonderful, really balanced view of the pros and cons of the single embryo transfer and bringing the patient perspective, which obviously reflects what you see in real life when you talk to these patients. So while people are coming up with some questions, or the panel sort of going forward with some comments or questions, can I just maybe ask, if I'm a patient and you want to counsel me about the option of single embryo transfer, what would you tell me?
So it really, as we let it out, it's practically a tailored matrix. So I would say that the age is always the main factor here, because it's so intertwined with the reproductive potential and the potential to actually produce chromosomically balanced embryos. So when it comes to time frame to achieve pregnancy, I would say that below the age of 37, I would use collectively a single embryo transfer. At least in Israel and the US, that's not the situation, because the mean age of patients who come for fertility treatments is roughly 14. So we could, if we don't use a PGT platform, we will probably often start with 2 embryos if these patients does not reach into a blast stage.
Okay, so what you're saying is that if I'm above, like 40, for example, or above, and you counsel me for the IVF, and I'm in the States or in Israel, you would actually do 2 embryos.
So, well, it really depends, because we can divide our patients into.
So let's say I'm 42.
So yeah, I would say that if you're 42 and your cycle performance, quote unquote, fits this age, you actually may have double embryo transfer on the very first cycle. Of course, according not only to these Israeli and American guidelines, but according to all societies. That's
interesting.
true.
So what's happening in Germany? So Kurt, is that, I mean, I don't know whether you know or not. I mean, it's obviously, I don't know whether it's your specialty, but is that the same in Germany?
Well, to be honest, I can't tell you, because I am not into art. But we see, I mean, quite often that they still do double embryo transfers with people coming from other countries. Not so much in Germany. I think they quite stick to the rule of only 1 embryo transfer, but it's rather ladies coming from other countries, and then you have the problems.
Okay, and if you want to, so back again, so let's say I'm actually 32, I'm going and want IVF. How would you counsel me in terms of the figures? So what would you say, look, if we do double embryo transfer, your risk of having twin or multiple pregnancies X, and if you do single embryo transfer, Y?
So I would say that again, if a 32 years old, otherwise with unknown infertility, we would definitely opt to single embryo transfer, at least in the first few cycles. We would expect, I would say, a cumulative reduction in the performance. I mean, in the first cycle, we would expect the highest fertility rates, and this would be declining towards as we progress in 10% and 25% in median in each subsequent cycle. So we should basically keep that in mind. Another, I think that one point that I do want to highlight here, and maybe that was not enough highlighted in the presentation, is that patient, basically the patient preference is pivotal. However, the picture that often the perinatologists see is based on a skewed population, on a survival bias, I would say, because the patients who actually reached your wards and your clinics, I mean MFM clinics, are highly selected among the population. They underwent a highly selective process. And that means that the patients who is basically 40 or 42 years old with a twin pregnancy is a really rare event, because
They don't seem to be rare.
Basically chances
The
to
clinics are
conceive,
full of them.
the chances, the actual absolute chances to conceive are lower, are basically around 3 or 2%. So yeah, it's when we're talking about populations, it could sound crude in terms of policy. Yeah.
Okay.
So I had one quick question. Sorry to interrupt.
Sure.
Is there a multi-marker algorithm that prior to embryo transfer can predict the optimal numbers of embryos you should be transferred based on the outcome that you want?
So that's a very great question. I would say that first of all, in terms of predicting success, we have constantly tried, and personally here also in Harvard University, we're trying to develop some algorithms and tools to predict success in implantations, both in toe and fresh cycles. And currently there are no good screening and algorithms using machine learning techniques or other more maybe simple statistical predictive models. We cannot do that, especially not in patients who have lower rate of conceptions. I mean, when it comes to, of course, PGT cycles, you would expect to have around 50 to 60% of per cycle success. But again, when it comes to the advanced maternal age population, your observed outcome will be much more difficult for the tool to predict success. So again, it comes together with the aneuploidity rates. We don't really have a good matrix to predict patients. Not well calibrated, and no, absolutely no.
Well, maybe that's a good idea for research project, especially with the use of AI or machine learning. It might be interesting to look at, and I'm sure people are trying to do that. At least I sort of am aware of some research activity in this field. So back again so maybe another quick question about the BGTA. So you seem to really sort of present the data and advocate the use of BGTA. I work in the UK and it's not that common. So when I see patients who had IVF outside the UK, majority have had the test, while in the UK, very few have the test. Do you have an idea why?
So yeah, of course, I think that the PGT is highly implemented in the US. I have to mention that throughout all the there have been an extensive research work trying to prove the superiority of this platform over not testing, and there have been no superiority, of course not. In the past, I say that before the New England Journal of Medicine paper that went out last year, people have the main approach was that it could shorten, PGT could shorten time to conceive, but that's probably not the case. There are some, as I mentioned, some off-label advantages for PGT here in this case. If we know the amount of ploid embryos that each patient have, we know that their implantation potential is high, so there is no reason absolutely to introduce into the uterus 2 haploid embryos, because we know that the chances of being pregnant is more than 50–60%. However, in other arena and for the broad IVF population, I think that it is I don't think I can advocate for the collective use of PGT, but I'm currently working in a place that offer more than 50–65% of the patients to use PGT for various reasons. So no, it's definitely not totally evidence-based, but it is not futile.
Okay, that's great. So it is still, the practice varies, and the evidence is not, you wouldn't say it's sort of robust enough really to justify routine implementation.
Absolutely.
Okay, so a quick question from Elizabeth Swinton. How common and where is it more common for more than 2 embryos to be transferred? Would this be linked to where embryonic testing is not common? So do you want to answer this question?
Yeah, I just want to read the question again because I haven't heard you, sorry. Would this be linked to where embryonic testing isn't common?
So I guess she's commenting on certain maybe countries, is that right? Or certain centers that maybe they're more likely to put more than 2 embryos.
So yes, definitely, yes. I would say that countries that are not adopting the PGT will definitely will go faster towards the double embryo transfer and maybe more. That doesn't mean that totally the numbers will be higher, because we have to remember that the patients with the diminished ovarian reserve and poor ovarian response maybe, an advanced maternal age patient would have this selection bias because they're not reaching to the embryos who are actually reachable for a biopsy, and that means that they will have a higher ceiling, basically a higher ceiling. So I would say my automatic response would be that yes, clinics that not using PGT will probably have more double embryo transfer. However, we have to remember that in certain European countries, there have been some penalties when it comes to introducing double embryo transfer, especially in the first cycles.
And just to say, we've been almost 3 hours in this workshop, which I have to say, I thoroughly enjoyed it. It was really great, and really grateful to the experts who shared their time on a Sunday to come and talk to us and share their expertise, and actually really to highlight the work that they've done with this paper. So really encourage everyone to download and read these articles and cite them in your future research, because they're really very, very valuable. So I'm gonna finish this webinar, but again, thanking the speakers, thanking the delegates, the people who actually joined the webinar and stayed for 3 hours, and highlight that the recordings will be available with the publisher Elsevier and also the Twin Trust for people who registered to, and other people who haven't registered to also access. And just to highlight that these articles are have also a list of practice points of the research agenda. So if you are a researcher and looking at what's your next research project, MCQs for people who want to have some material for their demonstration of your ongoing education and training. And just to highlight that this special issue had 21 articles. So these are the 6 of these articles that were presented and highlighted today. The next webinar was going to also focus on the special issue, would be on the 18th of December. So it's again, it's a Sunday in December. And just finally to thank Elsevier and the publisher for really highlighting and supporting this initiative, and for the staff, the journal staff, and for amazing the fellows, and particularly Jamila, who's helped with the coordination of the webinar, and she's sort of behind the scenes making sure that there's no technical problems. So on this end, just to say thank you very much. Enjoy the rest of your Sunday and have a lovely week. Thank you.